Today let's learn about adult polycystic kidney disease. Adult polycystic kidney disease is an autosomal dominant disease with prevalence of 1 in 1000. In this disease, small cysts develop within the kidneys that is lined with tubular epithelium. The cysts develop in infancy and childhood. It enlarges and normal kidney tissue is compressed that leads to progressive damage of the kidneys. There is mutation of PKD1 gene in 80% of the population that is coding for polycystin 1 gene, while in 15% of the population there is mutation of PKD2 gene that is coding for polycystin 2 gene. Then there is end-stage renal disease. Median age for end-stage renal disease for PKD1 mutation is 52 years. Means there is early onset of end-stage renal disease in patients with PKD1 mutation, while there is late onset of end-stage renal disease with patients with PKD2 mutation, that is 70 years. Then what are the clinical features of the patient? The patient may present with abdominal pain, that is maybe vague discomfort in loin or abdomen, but if the cyst ruptures or there is hemorrhage in the cyst, there will be acute pain. Then one or both kidneys may be palpable and they feel nodular. Then hematuria will be present in the patient with little or no proteinuria, and there will be renal failure. This disease is associated with hypertension that usually start at early 20s. There will be UTI and cyst infections. In brain there will be berry aneurysm in 5% of the population of patients with PKD. There will be aortic regurgitation or mitral regurgitation. Then in 30% of the population hepatic cyst may be present. There may be clonic diverticuli or abdominal wall hernia may be present. How we make the diagnosis? In patients with PKD, there will be a family history. There will be clinical findings that include renal pain or nodular palpable kidney. We do ultrasound examination, and in ultrasound, the patients over 20 years, 95% will be having a cyst. Then we have made a criteria for ultrasound to diagnose the patients with positive family history of PKD. If age is between 15 to 39 years and there are 3 unilateral or bilateral kidney cysts. If age is between 40 to 59 years and at least 2 cysts are present in each kidney, and in patients with 60 and above, at least 4 cysts will be present in each kidney. Then we can make a molecular diagnosis, and it will show mutation in PKD1 and PKD2 gene. Then we can do MRI angiography with patients with family history of subarachnoid hemorrhage to detect intracranial aneurysm, that will be berry aneurysms. Then how we treat the patient? We have to control the BP. As in renal diseases, there is increased risk of cardiovascular morbidity and mortality. There is no evidence that if we control the BP, we can slow the progression of end-stage renal disease, but we have to control BP to decrease the risk of cardiovascular mortality and morbidity. Then we can give tolvaptan to the patient, that is a vasopressin V2 receptor antagonist. Tolvaptan can slow the formation of cyst in some patients and reduce the volume of the kidneys. Then there are several risk factors that lead to the progression of disease, that include large kidneys, PKD1 mutation, positive family history for PKD, male patients, hypertension, proteinuria, and early symptomatic cyst. Then if end-stage renal disease has developed in patients, we manage it with dialysis and transplantation. While doing transplantation, we have to remove the kidneys that are already enlarged because they are the source of pain or infection in the patients. Thank you.